Good evening, my friends. First of all, my apologies for the delay in this is an integrated webinar. It's going to talk about COVID-19. We have four speakers who have actually researched this topic very well. Two of the speakers, Dr. Rajesh Parikh and Dr. Swapneil Parikh, have in fact written a book on the coronavirus and what we need to know during these pandemic times. Now, let me have this distinct pleasure and honor of introducing Dr. Rajesh Parikh. Dr. Rajesh Parikh is a neuropsychiatrist by training. He also practices psychiatry and he's the medical director of research at Jaslok Hospital and Research Center. He has many different aspects in his personality. On the academic front, he's also an adjunct professor of psychiatry at the University of Iowa School of Medicine. He has trained intensive faculty at Harvard, Yale, Johns Hopkins, and many hospitals in India. Rajesh is multifaceted. He has won 200 awards in different fields, which are also non-academic. And with this introduction, I welcome you, Dr. Rajesh Parikh, to deliver your interesting lecture on pandemics, particularly related to...
Apologies again, we're trying to get a hand on technology, and the moment we manage to understand one, it's time for another. To figure out how to use Skype 2 days ago, and then yesterday actually did the first webinar, and that was on Zoom. And by the end of the seminar, we figured out how to use Zoom. And presentation, okay, I'm hitting Command Tab, and yeah, I guess you can see the slides now. So what I'm going to do in the course of this presentation is just cover 100 years of pandemics and to see certain patterns which continue into the current pandemic, and to see what we really need to learn from the past so that we do not keep repeating our mistakes which have occurred time and again. Just a quick primer. I'm sure all of you know about this. What is an epidemic? What is an endemic disease? What's a pandemic disease? An endemic disease is one which is chronically present in a given population, not necessarily to a high degree. So for example, tuberculosis could be said to be endemic in India and many other countries. An epidemic disease is when there is a sudden spurt, a sudden rise in numbers of a disease in a particular area. Then we say we have an epidemic. So for example, COVID-19 started as an epidemic in Wuhan. And when it spreads to different countries and various continents, that's the time when we call it a pandemic. And that's what we are currently dealing with. Okay, I'm trying to forward this slide. And could somebody help me forward this, because it doesn't seem to be forwarding. So we're stuck on this slide. How do we move to the next one? Maybe here. All right, there you go. I figured it out. The biggest pandemic of them all, the mother of all pandemics, though it's not talked of very often, and 1920. 500 million people across the world were affected by it. And let's keep in mind that the population of the world at that time was 1.8 billion. The population of India today is 1.3 billion. So about a third of mankind was affected by it, and the estimates were between 50 and 100 million deaths. But recent looking at the data again tells us it was closer to 100 million people. So just imagine, more people died in the Spanish flu pandemic than in World War I, which preceded it, and World War II, which followed it. It was called the Spanish flu for interesting reasons. Actually, it was the American flu. It started in Kansas in the US. Not much was talked about it because at that time, due to World War I, there was the War Secrecies Act in many countries, and you had to get past the censors to talk about it. King Alphonse III fell seriously ill, and although he survived, the court tried to keep it a secret, but word leaked out, and the Spanish media was not covered by the War Secrecies Act. So they started talking a lot about the illness, and that's how it got known as the Spanish flu. Now, we saw a similar pattern in the current pandemic. It started in Wuhan, and For almost a month, the Chinese media, the Chinese Politburo tried to keep it under wraps, and then information spread faster than the virus. It's not for nothing they call it viral, and people got to know about it. Then following that, there was the Asian flu pandemic in 57, 58. About 250 million to a billion were affected, and somewhere between 1 and 4 million died. And then you had the Hong Kong flu pandemic. Again, look at these large numbers of people who are getting affected and dying. And then you have the swine flu pandemic. Why have I gone back? We have the swine flu pandemic. And again, you see the large number of people who are affected. So most of us will remember this because there's a lot of discussion around swine flu. And what is common to all of these? They're zoonotic. They all begun with birds or animals and spread to humans. And another important thing for us to learn, and we wrote about this book in late January and early February, is what happened during the swine flu pandemic is the WHO at the appropriate time declared it as a pandemic. That was sometime in March of 2009. Vaccine development was accelerated. The vaccine was ready, surprisingly very early, by sometime in November. But by that time, the pandemic, for natural reasons, had abated and it was down. Now, after everything had settled, the WHO came under a lot of criticism for declaring it a pandemic, although they had done the right thing. And an editorial appeared in the British Medical Journal in which they found out that some of the advisors to WHO were also advisors to pharmaceutical and biotech companies, which were vaccine manufacturers. And so there was a clear conflict of interest. And the editorial implied that this conflict of interest might have driven the WHO to declare swine flu as a pandemic. The Director General of the WHO, Margaret Chen, wrote a very strong letter, and I suggest you read it. And in that letter, she pointed out that there are very definite criteria for calling an epidemic a pandemic, and nobody can bend them one way or the other. And all criteria had been followed. So this is what happened in 2009. And now in January and February, when we started working on our book, and at that time, mind you, the epidemic, as we should call it rightly, was mostly around Wuhan and within China. We anticipated that the 2009 criticism of the WHO might hold it back this time from declaring it a pandemic until it was a bit too late. And our fears came true. This time, WHO was the last to call COVID-19 a pandemic. Much after everybody had called it a pandemic, they did it in February, and they were possibly driven by the experience in 2009. Now, this graphic shows you the ratios of the deaths worldwide, and within that, the estimate number of US deaths. So we see with the Spanish flu or the American flu, whatever you'd like to call it, that, let me go back. Okay, that while they might, this is greater than 50 million, now we know it's closer to 100 million. These were the deaths across the world, and this small number here is the death in the US. And this was 100 years ago. And then we look at what happened in 57, 58, what happened in 68, 69, and what happened with swine flu. What I'd like to point out, just see how small the US numbers are, because the US is advanced in medical science. It has the highest number of Nobel laureates. It has scientists, it has technology, it has money. And so for 100 years, the number of US deaths were low. But now see what has happened this year. This is COVID-19. You can see as of yesterday, the US deaths are in excess of 78,000, whereas the world deaths are 275,000. And here's the tragedy, in spite of science, in spite of technology, in spite of information being freely available, there was ignorance, there was ineptitude in the powers that be. And today, the US has the largest proportion of deaths, more than any third world country anywhere. Okay, and now here's another lesson for us to learn, and so that we don't get lulled into a false sense of complacency or security. With the Spanish flu, there were 3 waves. Okay, And let's say there was a second wave. So these are like tsunami waves. The first one comes in, goes off, everybody relaxes, thinks the worst is over, and then comes a second one because the virus can mutate and usually does mutate. And the second one was worse than the first. And then you had a third wave, which was not as bad as the second wave, but still worse than the first. So it's important for us to realize this and keep it in mind because we have to be prepared. The lockdown will get lifted, things will get back to normal, and then we might have a second wave. Hopefully, it won't be as bad as the first wave. There have been minor waves in China and in South Korea, and they were smaller than the first wave. So let's hope that's the pattern that we see. And again, this picture from the past will resonate with those of us who are seeing the photographs from today. Stadia are being converted into treatment centers, the NSCI Dome in Mumbai, for example. And this is more or less how the cots are laid down. So 100 years later, we're pretty much doing the same thing. And, it was George Santayana who once said that, those of us who do not read history are condemned to repeat it. And this is often misquoted as saying those who do not learn the lessons of history are condemned to repeat it, but that's more or less the same thing. And here are other viral outbreaks. Let us not forget, the HIV pandemic is not over. Nobody is talking about it now because we have something else in front of us. But there have been 32 million deaths with HIV, 75 million people infected, and it is still a pandemic. Then there was the Ebola epidemic. And now if you look over here, there are under 30,000 people infected, but see the large proportion of deaths, 11,310 deaths. And then you had another variant of the Ebola epidemic. It's 2018, still going on. And here 3,400 people were infected, but a large proportion of them died. So there are viruses which spread very easily, but do not cause a lot of deaths. And there are others which don't spread so much, but are fatal. The COVID-19 pandemic, in that we are seeing that the spread is very rapid. The mortality rate we will see is not that high. And then with the Zika epidemic, the deaths were few, the spread was large. And just a quick recap of all of this. With SARS, with H1N1, with MERS, seasonal flu, Ebola, you can see the country of origin, you can see the number of people who were infected, and you can see the fatality percentage. And again, it's animals. All of them are zoonotic. And here is a poster from the 1918 pandemic, which, you'll recollect, killed almost 100 million people, and a current poster today. And you will see we're still talking of more or less the same things, coughing, staying clear. It's just like they were a modern version of this earlier poster. There's a French saying, plus ça change, plus la même chose. The more the change, the more we see the same thing. Now, it is not the purpose of this symposium, of this webinar, to go into details over COVID-19, because this has been talked about extensively. We will touch upon it where it is relevant. But I think most of us have attended a lot of webinars on COVID-19. In this one, we are covering something, as Firuza indicated, which is somewhat different in that, I've talked about the history. Dr. Rishabh Mishra will talk about what's happening currently in New York. He's at the front lines over there. And then we'll have, Swapneil Parikh talk about something that's very important and relevant to us, which is what do we need to do to make our clinics and our practices COVID-19 safe. And then Firuza will talk about reproduction and COVID-19. So these are things that you're aware of. It's just a recap about the incubation period, how long a person is infectious, the R0, which is how many people get infected by one index person. And in the case of COVID-19, it's between 2 and 3. That's pretty high. That means one person who is infected, regardless of whether he's symptomatic or not, can infect between 2 and 3 people. And that's why it's spreading so rapidly. And this is, again, data from studies now across the world. About 80% of cases are mild, so mild that they may not even realize they're infected. but they can infect other people. About 15% are severe, 5% get critical, and somewhere between 1 and 2% die, though that varies depending on other comorbid conditions. And men are at greater risk than women. We all know today is Mother's Day, so happy Mother's Day to all the moms over there. And you're tougher than us, okay? And here's the proof, okay? You do much better with COVID-19. The virus is more scared of you than we are, because the virus knows we are scared of you, so the virus is also scared of you. And people who are over 65 and people who have comorbid conditions, I think I have one more slide where I just cover some of these conditions. So if there is no comorbidity, then the general figure, average figure, is a mortality of 1.4%. It's still very high because so many people are being infected across the world. The numbers are high, the percentage may not be. And then when you have comorbidity, it varies. It's 13.2% in people with cardiovascular disease, over 9% with those with diabetes, 8% those with hypertension, with any kind of chronic COPD and other chronic respiratory diseases, about 8%, cancer, it's 7.6%. Now, let us not forget that these are individual. Quite often, people also have comorbidity between this. So somebody with cardiovascular disease could easily have hypertension and could have diabetes as well. And if that person has been smoking, there's a high possibility of these. So the risk gets adds on. And so this is the broad outline. What I have covered in this talk is over 100 years, we've had other epidemics and pandemics. Unfortunately, we've not learned enough from them. For 75 years, scientists in increasingly loud voices have been asking governments for increased funding. A pandemic of this kind has been predicted many times, but the powers that be have not listened to the scientists, and that's where we are today. Let us see what we can do today to cope with this pandemic, to master it, to be able to survive through it, and then hopefully learn some lessons for the future. The next speaker is Dr. Rishabh Mishra. Rishabh is an assistant professor at the Albert Einstein College of Medicine. He's right on the front line. He's in the ICUs, seeing patients at the Montefiore Medical Center in New York. He is also medical director of Reliant MD, which is a digital healthcare enterprise. He has a profound interest in serving the underprivileged. He keeps coming to India and going to small villages in Uttar Pradesh and elsewhere, working on a project which he initiated with the Tata Trust and the UP government in over 100 villages to get them ready for Japanese encephalitis. He's also a senior advisor on the Business Council on Healthcare India and for the GCC. And I should add, he's my physician. If I have any health issues, which I've had from time to time, Rishabh is my first point of contact. He gives me the latest advice. I don't always follow it, but I think you'll find Rishabh's talk very interesting. Thank you. Over to Rishabh.
So good evening, everyone. I'm Dr. Rishabh Mishra. I practice acute medicine at Albert Einstein College of Medicine in New York. I would like to thank Dr. Firuza Parikh for having me here. So today I'm going to share about some inpatient essentials in the management of COVID-19 in an inpatient setting. My talk will be mostly focusing on my experiences as well as my institutional experience. So let's begin. There are several theories around the origin of SARS-CoV. In general, our understanding is that serves as a primary reservoir. Humans got infected through pangolin, which acted as an intermediate reservoir for this virus. It is believed that the pangolin were brought to the Chinese market illegally, and that led to the zoonotic transfer to the humans and the pandemic spread. But obviously, there are a lot of controversial theories going around. So the virus infects the lung through ACE2 inhibitors, which is predominantly found in the distal airways and type 2 pneumocytes. The virus spike protein binds to the virus and type 2 transmembrane serine protease binds and cleaves the ACE2 inhibitor, leading to the virus entry into the cell. The imbalance between the pro-inflammatory and the anti-inflammatory process causes lung injury as well as the ARDS. So the presenting symptoms in these patients are fever, shortness of breath, fatigue, sore throat, dry cough, headache, anorexia, myalgia, dyspnea, anosmia, abdominal pain, and diarrhea. And something important to mention is that we see a lot of asymptomatic patients too. Few days ago, I had a patient who came to the ER with back pain. And since now we are testing all the patients for COVID in order to cohort their admission, we had to test him and he came to be positive. The risk factors for severe COVID are age greater than 65, pre-existing lung conditions like COPD, asthma, chronic kidney disease, diabetes, history of hypertension, history of cardiovascular disease, a BMI of more than 30, patients who are on immunosuppression and biologics, and also HIV patients with CD4 less than 200. So the sample is generally collected through nasal as well as pharyngeal mucosa. We are currently using PCR testing at our hospitals. And for adequate sample collection, we suggest to swipe the swab on the walls, on all the 4 walls of the pharynx, and also swirl the swab for 15 seconds deeply in the nares. So something important during the search is to triage the patient. So hypoxia is an important criteria to decide whether a patient needs admission. If saturation is greater than 95% and no additional risk factors are present, we can safely discharge these patients with an isolation of 2 weeks. Generally, we try to provide these patients a pulse oximeter and enroll them to our telemedicine program for close follow-up. For patients saturating between 91 to 94%, we should strongly consider admission in patients with age greater than 65 with risk factors like chronic lung disease, kidney or liver disease, and active immunosuppression. Also, regardless of the age, we should admit patients if the patients are showing signs of severe lung infections like dyspnea and exertion, tachypnea, and bilateral infiltrates. All the patients with saturation less than 90 should be treated and observed very closely. And chest X-ray with viral pneumonia is not a definite indication for an admission. So on admission, we get a comprehensive lab for these patients, which includes CBC with basic metabolic panel and magnesium. We also get cardiac enzyme markers along with cytokine markers, which includes LDH, CRP, ferritin, and BNP. If the patients are improving, generally we go ahead and get just routine labs with CBC, BMP, and magnesium and try to get alternate labs for cytokine markers as well as cardiac enzyme markers. If we notice signs of clinical worsening, that is when we consider CBC with differential along with all the markers of cytokine storm, along with the cardiac enzyme markers as well as hypercoagulable state markers. So the lab indicators of severe COVID are D-dimer greater than 1000, CRP greater than 100, LDH more than 250, troponin greater than 2 times the upper limit of normal, ferritin which is greater than 500 milligram, and CPK greater than twice. Also, an absolute lymphocyte count of less than 800 is a marker of severe COVID infection. So we get chest X-rays for all the patients with COVID disease. It's generally normal in 20% of the cases. We see varied level of lung involvement with mostly interstitial infiltrate pattern, either unilateral or bilateral lung involvement. CT chest is actually not generally required unless you're concerned for other pathologies like pulmonary embolism. The most common finding is of CAT scan is bilateral peripheral distribution of infiltrates and involvement of lower lobes. We also observe ground glass opacification with or without consolidative changes. So this slide explains the disease progression. The stage 1 involves the initial stage, which occurs at the time of the inoculation and early establishment of the disease. This phase is associated with mild and often non-specific symptoms such as malaise, fever, and a dry cough. During this period, SARS virus multiplies and establishes residence in the host, primarily focusing on the respiratory system. During stage 2, patient develops a viral pneumonia with cough, fever, and possible hypoxia. It is at this stage that most patients with COVID-19 would actually require hospitalization for close observation and management. Minority of these patients actually transition into the third and the most severe stage of the illness, which manifests as extrapulmonary systemic hyperinflammation syndrome. In this stage, markers of systemic inflammation seem to be elevated, and in this phase, we should consider treating with anti-inflammatory agents like IL-1 or IL-6 inhibitors. So, empiric management is actually supportive treatment for mild to moderate cases. We should never forget that it's a viral illness, so supportive treatment is the mainstay treatment goal. Oxygen therapy with a goal of greater than 92% is recommended. If the oxygen saturation persistently drops less than 92% and 100% of non-rebreather mass, we should switch these patients to high-flow nasal cannula or non-invasive ventilation in a negative pressure room. Tylenol or paracetamol is the preferred antipyretic agent, given the fact that there is a lot of uncertainty around the NSAID. While using inhaled bronchodilator, we should administer them using metered dose inhalers and avoid any nebulizer treatment. And avoid any nebulizer treatment in order to prevent aerosolization and transmission of infection within the hospital. Unless sepsis is suspected, we should aim for a conservative fluid replacement therapy. So early intervention strategy for patients whose clinical status is not improving is to change the ventilation from non-rebreather to high-flow nasal cannula or a non-invasive ventilation. Actually, this is in complete reversal of our earlier strategy of early intubation for these patients. Also, we should also immediately initiate awake proning for these patients. Awake proning helps by recruiting collapsed alveoli in the posterior part of the lungs, also helps in increase in secretion drainage, and improves the perfusion in the anterior part of the lungs where you see more healthier alveoli. If the symptoms still don't improve, a trial of steroids can be tried on a case-to-case basis, and which I'll touch upon the next. Once the patient is intubated, ventilation should be based on lung protective strategy with lower tidal volumes, lower inspiratory pressures, and higher PEEP. Steroid therapy is generally reserved in case of CRP greater than 20 and if we are suspecting impending respiratory failure. We dose steroid gram per kilogram body weight, and at the same time, we should also assess for cytokine storm by sending ferritin, CRP, LDH, and CBC. If these markers are elevated, we should consider administering anti-inflammatory medications like IL inhibitors. Our retrospective studies at our institution have actually shown that steroids should be used cautiously in patients with CRP less than 10 and age less than 40. So again, steroid use for CRP more than 20 and patients with impending respiratory failure. So some important pearls to be kept in mind while treating these patients in the hospital is Very important to mask all your patients while in inpatient setting. Also, we have seen rapid worsening of hypoxia and clinical decompensation, which might occur within hours in these patients. These patients are also at a high risk of hypercoagulable state. Also, we see the diabetics progress to diabetic ketoacidosis and also hyperglycemic hyperosmolar state. Awake proning helps significantly, and also you see these patients come up with acute kidney injury, and transaminitis is a very common finding. So antibiotic use for pneumonia there has been a little controversy whether to use antibiotic or not. The data shows that in patients with confirmed COVID-19 pneumonia, secondary bacterial infection is uncommon. So initiation of antibiotic therapy solely due to confirmation of COVID-19 pneumonia is not really indicated. We should consider antibiotic if we observe leukocytosis and also hemodynamic instability. Procalcitonin can be a great tool which can help us decide if a patient would need antibiotic. Generally, bacterial co-infection is unlikely if there is a low procalcitonin level, and that level is less than 0.25. As already mentioned, COVID leads to go back to medical school and think about the Virchow's triad of endothelial injury, stasis, and hypercoagulable state happens in the COVID infection. So endothelial injury occurs due to the direct invasion of the endothelial cells by the SARS-CoV-2 virus, and also due to the mediation of acute systemic inflammatory response due to the viral infection. Also, these patients are immobilized due to the hospitalization, and there is a hypercoagulable state due to increase in the prothrombic factors like elevated factor VIII, fibrinogen, and neutrophil extracellular traps. This all leads to increased formation. So all patients due to COVID receive anticoagulation treatment unless there are some contraindications. These contraindications are platelet count around 50,000, Child-Perk's class C liver disease in less than 8, and also any evidence of bleeding. D-dimer is an important tool to assess between use of therapeutic versus prophylactic strategy for anticoagulation use. If a patient has a D-dimer of less than or equal to 2, should start thromboprophylaxis treatment with apixaban of 2.5 milligram or enoxaparin of 40 milligram daily. If a patient is obese, we should consider enoxaparin for 30 milligram BID. In case the D-dimer is greater than 2, we should consider therapeutic anticoagulation with apixaban 5 milligram and enoxaparin 1.5 milligram per kilogram body weight. Something to note is we should try to assess these patients for signs of, in case DVT is suspected, we should immediately get an ultrasound duplex to check for deep venous thrombosis. All these patients on discharge get 3 to 4 weeks of anticoagulation therapy, and on discharge, the PMD decides where the patient again needs anticoagulation for an extended time period. So next slide. This is a slide which covers mostly medications which are under study or is being used at my institution here at Einstein. So I would try to throw some light on each of them and explain them briefly. None of them except remdesivir has been actually approved to be used in treatment of COVID. So hydroxychloroquine, remdesivir, IL-6 inhibitors, IL-1 inhibitors, convalescent plasma, and other agents like avigan, leronlimab, and mesenchymal stem cells are being used at different level of trials in the US. Let's begin with hydroxychloroquine, which has created a lot of press recently. So to mention, there's insufficient data out there on the effectiveness of hydroxychloroquine. And there's still no clear evidence of clinical benefit with either hydroxychloroquine or chloroquine, especially in the critically ill patients. So widespread use of hydroxychloroquine outside of clinical trial is no longer recommended. And we have stopped using it at our institution, except in the case of ORCID trial, where the patients are enrolled and explained about the side effects of these medications. Something to be wary about it is it causes QT prolongation and also arrhythmia in the admitted patients. So remdesivir is a novel nucleotide analog which inhibits viral RNA-dependent RNA polymerase and prevents viral replication phase. The preliminary results from NIH clinical trials showed that the patient who received remdesivir had a 31% faster time to recovery than those who received placebo. Also, a survival benefit was seen with a mortality rate of 8% for the group receiving remdesivir versus 11.6 for the placebo group. Seeing these results, FDA issued emergency use authorization for this medication. We generally give 200 milligram IV as a loading dose for this medication, then 100 milligram IV daily for 5 to 10 days. Something to note is that a drug that inhibits viral replication may be of little use once the virus replication has reached its peak. So most of these trials utilize remdesivir at stage 2B or 3 of the infection. So there's a possibility that it might be more effective if used in the early stage of the treatment, and that is why there are some trials which are being devised, by using the drug at the early phase of infection. I would like to mention 4 recently published studies on the use of remdesivir. If we can see, the severe RCT study in China showed no difference in 28-day mortality as well as time to recovery, but something to note is the studied subjects were fewer when compared to the adaptive study, which showed that there was a reduction in the mortality and improved time to recovery in the remdesivir arm. There are ongoing studies around remdesivir. The adaptive study now also uses baricitinib as an adjuvant. Also, there are several other studies which compare the shorter versus longer course of therapy and comparison of remdesivir with other therapeutic regimens. So remdesivir can cause transaminase elevation, and the use is discontinued if ALT is greater than 5 times the upper limit of normal. Even though we have the FDA emergency use authorization, the challenge we find ourselves is that there is no treatment guideline, and also there's there's not a wide availability of the drug in the market. So basically, we have to rely on the trials in order to get these medications for our patients. So IL-6 pathway inhibitors include tocilizumab and sarilumab. These are humanized monoclonal antibody against IL-6 receptors. They bind to the membrane-bound and soluble forms of IL-6 receptors and inhibit signal transduction and activation of inflammatory pathways. Cytokine storm is actually an immune response in a viral infection and is not a new concept. The parameters which shows cytokine storm in a patient are worsening clinical spectrum, ferritin greater than 300 with doubling within 24 hours, ferritin greater than 600 at presentation, LDH greater than 250, and elevated D-dimer of greater than 1 milligram per liter. Something to be noted is this medication is still under investigation and so can be used only off-label for your patients. All the patients who are receiving tocilizumab should be checked for latent TB before administration. Tocilizumab is generally dosed at 400 milligram IV times 1. Dose may be repeated 12 hours later if an inadequate response is noted to the first dose. Sarilumab is in the randomized phase 2 portion of the trial and is being used at 400 milligram or 200 milligram depending on the arm of the trial. We cannot use this drug as an off-label. Caution to be noted while using IL-6 inhibitors are transaminitis, infusion reactions, hypercholesterolemia, reactivation of lung TB or fungal infection, neutropenia, and bowel perforation if there is a history of diverticulitis. So anakinra is a recombinant human interleukin-1 receptor antagonist. It competitively inhibits IL-1 binding to IL-1 type 1 receptor. The use is only off-label and it's used in cytokine storm. Dose is generally 300 milligram IV every 24 hours once or in a divided dose for 7 to 28 days. Caution is generally noted. Caution is considered while using anakinra, which includes increased incidence of infection, neutropenia, anaphylaxis reaction, as well as injection site reaction. So convalescent plasma actually includes harvested antibodies from recovered patients for administration to acutely ill patients. This results in passive immunity and is thought to confer immunity for weeks to months. Donors need to have an IgG antibody titer level of greater than 1:80. Currently, we have had mixed experiences while using convalescent plasma. Worst outcome is most likely due to antibody-dependent infection enhancement through pro-inflammatory cytokine activation. Currently, we are using 1 unit of convalescent plasma and we wait for 24 to 48 hours to assess the symptoms. If there is no improvement, we plan a trial of one more unit to assess the response. Adverse reactions are noted as similar to human blood product administration. Life-threatening reactions include transfusion-related acute lung injury, transfusion-associated circulatory overload, and anaphylactic reaction. We should immediately stop the transfusion if we suspect life-threatening infusion reaction. In case of non-life-threatening events, we should consider pre-treatment with Tylenol and Benadryl, and a trial of slow infusion should be tried. Also, something to be noted is convalescent plasma leads to, convalescent plasma is an equivalent of fresh frozen plasma and leads to the lowering of INR. All patients on convalescent plasma and warfarin need their INR to be monitored regularly. Something to mention is that a lot of these medications are actually under trial, and we are still in the search of a silver bullet therapy which can effectively prevent the disease progression in humans. I would like to mention a few points about some vaccine candidates being studied and different companies utilizing different concepts. In the US, Pfizer and Moderna have begun vaccine trials. Their candidate is an mRNA-based vaccine. The mRNA produces antigen in the body, and then antigen leads to the antibody production, which produces immunity. Currently, there are no mRNA-based vaccine approved for human use for any of the disease. That's why immunologists have doubt on this technology. But we never know, this can work for coronavirus. In the UK, Oxford vaccine group started their trial last month. It is based on the adenovirus genetic material. They mentioned that the vaccine trial was successful in monkeys, which is actually a very positive sign. Johnson & Johnson is also projecting their first human trial in the fall. Their vaccine is actually a viral vector-based vaccine, and they had a success with Ebola vaccine using the same concept. Sanofi is working on the protein-based vaccine candidate. That's a robust and the most successful platform, as they use the same concept to produce their flu block vaccine for influenza. Their human trial is projected to start this fall too. So I was just going to the clinicaltrial.gov and I found out that there are more than 70 vaccine candidates globally. Historically, 1/3 of the vaccine in trials succeeds, so I'm optimistic someone will succeed soon, as there is an urgency. The challenge will be to ramp up this production in a very short duration of time so that the whole world can benefit it in a short time. So I will end my presentation with this art from Charles Mackay, which holds a lot of relevance in the current pandemic. We don't need to fight the storm, said the horse. If we are still, it will pass. Thank you, guys.
Okay, so yes. Okay, so thank you. That was a excellent talk, and I hope the storm you were referring to was not the cytokine storm, for which there are a lot of things that people like you do. We're very proud of the tremendous work you're doing on the front lines. And now it's time to introduce the next speaker, Dr. Firuza Parikh. As you can see, she has several degrees. The most interesting one of them, to my mind at least, is the PhD, which she got about, I think, 2 or 3 years ago. She worked on it for over almost 10 years, trying to get data under the guidance and help of Dr. Prochi Madan and Arundhati Athale. And, for 2 days before the exams, she was as nervous as a third MBBS student. And so that's the latest of her degrees. In many of these, she's got gold medals. She is the director of the Fertility Jaslok International Center. It gets patients, or it has got patients from over 65 different countries in the world. And, the babies are all over. And she's on the editorial board of these 2 journals. Her team, her incredible team, has delivered more than 15,000 babies. Most of them have been part of the team for 20 years or so, at least. And in addition to these 15,000 babies, we have 6 other babies of our own. So, she also produces babies at home. And many babies across the world, I've lost count how many, have been named after her. There are baby Firuzas roaming around in New York, Paris, Johannesburg, Chennai, Srinagar, London. And she truly believes that they are her babies and maintains albums of all of these babies. She has many scientific publications, book chapters, has received several awards. 15 years ago, she was in the coveted India Today list of the 50 most powerful people in the country. A few years later, she was on the Indian Express list of the 10 most important doctors in the country. And she just keeps featuring on various lists. Our list at home, of course, she's the best mom in the house. And so happy Mother's Day to you, Firuza. And, she sometimes thinks I also, although I'm older than her, was another of her children, but that's for some other symposium. And they've had several firsts. This one is particularly interesting because, there was a woman with a very strong family history of cancer. And, she herself tested positive for cancer genes. And they used PGD to ensure that the babies she had were free from this mutation. And now for several years, they've been getting awards of the best IVF center in India, West Zone, Mumbai. So, that's Firuza Parikh for you. And happy Mother's Day, and look forward to your talk, Firuza.
To talk about how women have been affected in the times of COVID-19 and what are the differences in how men and women react to SARS-CoV-2. Look at this little illustration. Look at the face of the man. He's extremely scared of this virus and he's doing all the wrong things. He has a look of despair on his face, touching the T-zone. He's handling his mask in an inappropriate way. And perhaps that may be one of the reasons why men have more morbidity in COVID-19. Look at this elegant peacock. Have you ever seen a peacock in the middle of a Wednesday afternoon in South Bombay? Well, I haven't, but I have after this pandemic started. And look at these peahens. The male peacock is elegant, looks very handsome, and these tiny peahens look very insignificant. But perhaps this is where there is a difference between the male and the female. And we are going to touch upon some of the reasons why men perform more poorly than women with COVID-19. So we are going to first touch upon two conditions. One is the infertile condition and one is the pregnant condition. Now both of these are very important to discuss because both situations cannot be classified as elective. This is a very vulnerable population and therefore treatment of these conditions need innovative solutions and great care. We have to deal not only with the pregnant woman, we have to consider her partner, her baby. If there is infertility when the woman has fallen pregnant, that is something to consider. We have to look at the caretakers and society at large. When we are talking about the infertile couple and treatment of infertile couples, we have to look out for many factors. The oocyte, the sperm, embryos, the biological clock, particularly in older women. What are the different IVF procedures that we have to offer and what impact would these have on the mother and what impact would the virus have on these procedures? We have to consider the baby, the partner, the mode of delivery, whether breastfeeding can be carried out, then also testing in these circumstances and the emotional and reproductive cost of aging. My lecture is going to concentrate on these differences between men and women as also discussing the reproductive system. Now, before we embark on this lecture, let's look at some basic things of the coronavirus SARS-CoV-2. We all are familiar with this diagram, but I like to use an acronym which says MEMS. So, the virus consists of the membrane coat or the membrane protein, the envelope, the spike protein. Remember it as MEMS. And if you see, it is the spike protein, the envelope protein, and the membrane glycoprotein, which creates the viral envelope, covering the single-stranded RNA. So now let's look at the oocyte and the embryo. I'd rather discuss about the embryo at this point because our main concern is with embryo because oocytes are protected by the zona pellucida, whereas the embryo, as it develops, may have breaches in the zona pellucida. So if you look at this cartoon, it will show you that the ACE receptor is located on both the chromosomes in the female, the X and the X. This ACE receptor is present in many organs and tissues, including the lungs, the arteries, the heart, the kidneys, intestines, and the brain. Certain parts of the brain, like the cerebral cortex and the hypothalamus. Now, the function of the ACE2 receptor is to counter the effect of ACE, which in some ways works against some people, and in women, it works for them because they have two X chromosomes. So, how does this whole mechanism work? So, the spike protein of the virus attaches like a key and lock mechanism to the ACE2 receptors. With the help of endocytosis and translocation into in the endosomes, this virus now starts moving inside the cell. However, priming of this virus and priming of the whole mechanism has to occur, by which the host cell's transmembrane serine protease 2 has to get activated. What this TMPRSS2 does is it cuts open the S protein and therefore exposes a fusion peptide. Now this virion has a way of entering the cell, it releases its RNA into the cell and now forces the cell to produce and disseminate copies of the virus, which then infect more cells. This is a very nice cartoon which has been shared by my friend Dr. Deepak Modi. And here, what he has shown, he has looked at the transcriptomes of some embryos, and what they have shown is in the oocytes, there are receptors for SARS-CoV-2, but they are less in number. The TMPRSS2 is not present. The receptor ACE2 is present in the zygote, but in a less amount, but it dramatically increases at the blastocyst stage. And this is beautifully seen in all these three diagrams. The middle diagram shows the ACE2 receptor, and on the extreme right shows the expression of TMPRSS2. So Deepak and his group wrote out a paper which was recently published, and what they showed is that they investigated whether the SARS-CoV-2 can affect early human embryos, because if it did, then whether it would be wise to expose these embryos to the environment with the risk of them getting infected with the virus. So they analyzed the single cell RNA sequence datasets of human embryos, and they looked for the receptors ACE2 and also for bassigin. So they also looked at serine protease TMPRSS2 for seeing whether these could prime the spike protein, and they looked for the endosomal protease CTSL. And what they showed that both of these are co-expressed in a proportion of the epiblast cells, and both BSG and CTSL expressed in all stages of embryonic development. So in the conclusion of the paper, they expressed their caution in trying to conceive with IVF because the eggs and the embryos and the sperm are exposed to the environment in these trying pandemic times. This paper received some critique in a recent webinar where the speaker expressed concern that the data sets only applied for 11 or 12 embryos. Although I agree with the speaker that these are less number of embryos, this is an extremely important paper, and this only calls for more papers in this direction. Now, let us look at two other papers which have talked about whether SARS-CoV-2 would be present in the semen of males, and from that extrapolating whether the testicular tissue would be involved. So there is a recent paper in Fertile Sterile by Pang et al., and their objective was to describe the detection of SARS-CoV-2 in the seminal fluid of males who were recovering from COVID-19, and also to describe the expression profile for ACE2 and TMPRSS2 within the testicle. So they looked at 34 adult Chinese men who had gone through COVID-19 in the recent past. Their main outcome measures were to look out for SARS-CoV-2 by using the qRT-PCR technique and looking at the ejaculated semen samples. At that point in time, they did not do a semen analysis, and they also saw whether ACE2 and TMPRSS2 were expressed in the human testes by looking at previously transcriptome datasets. Now, 6 patients demonstrated scrotal discomfort suggestive of testicular inflammation or otitis around the time. However, they also looked at the semen, but after a median of 31 days, so that is quite a prolonged time after actually contracting the virus, and they did not demonstrate any virus presence in the semen. When looking at SC transcriptome analysis, they showed that there was very sparse expression of ACE2 and TMPRSS2, and there was no overlapping gene expression in this group. So they concluded they did not find the virus in the semen of these patients who were recovering from COVID-19. The ACE2-mediated viral entry of the SARS-CoV-2 virus in the target host cells was therefore unlikely to occur within the human testicle based on this expression. However, they also said cautiously that the long-term effects of this virus were not known on the male reproductive system. Around the same time, in the same month of April, there was another very interesting paper by Wang and Zhu in the journal Cells. And what they showed that when they profiled by RNA sequencing the human testes, they found the presence of ACE2 receptors, then these which are a target for the SARS-CoV-2 infection in spermatogonia, Leydig and Sertoli cells. So they wanted to find out whether the reproductive system of the male was a potential target for this infection, and because it was not earlier determined. So they wanted to investigate the expression pattern of ACE2 in adult human testes at the level of single cell transcriptomes. And what they saw was that ACE2 was predominantly enriched in spermatogonia, Leydig and Sertoli cells. So they concluded that these findings could provide evidence that the human testes becomes a potential target for this infection. So in the same month, two contrary papers. Let me add here that the science is still evolving. We are learning a lot, not only month by month and week by week, but from day to day. And this is an important lesson in showing us how COVID-19 is evolving. Pregnant woman and her baby. So this is another paper which came from NIRRH by Mahale, Deepak Modi and group. And here it's a very interesting, very good systematic review. And to define this review, they had 172 women who were affected by COVID-19 when they were pregnant. There were 160 women who achieved 162 newborns. And what they found that the common symptoms in these women were fever, cough, myalgia, dyspnea, and diarrhea. In 100% of these women, pneumonia was diagnosed by CT. And some of the pregnancy complications included cesarean section, preterm labor, fetal distress, and premature rupture of membranes. The most common comorbidities that were seen were diabetes, high blood pressure, placental disorders, co-infections, scarred uterus, hypothyroidism, and anemia. When they looked at the neonates, they found that preterm birth, respiratory distress syndrome, pneumonia, low birth weight, and small for gestational age was prevalent. There was one stillbirth and one neonatal death. But interestingly, what I want you to concentrate on is that the vertical transmission rate of SARS-CoV-2 was estimated to be around 11%. Now, this is a little worrisome because earlier studies had said that there was no vertical transmission. So now as science is evolving, as we are learning more about COVID-19, we are seeing that babies or neonates can be affected in utero. The conclusion that they drew was that pregnant women with COVID-19 who have diabetes and hypertension have more risk of preterm delivery. Many of these neonates can have respiratory distress syndrome and pneumonia, and that there is a vertical transmission of SARS-CoV-2 infection in women with COVID-19. So this paper showed that there was a possible vertical transmission of about 11%. This was by looking at the antibody testing. So this study again highlights that there is a risk of vertical transmission. Comorbid conditions in the mother makes them more prone to morbid conditions or a morbid outcome of the COVID-19 infection. So before we move on to our actual discussion about the difference between the male and the female vis-a-vis the COVID-19 infection, let me just say a few kind words about the nurses and the other healthcare workers who are helping us in this crisis. They are actually our frontline workers. The nursing system is currently overwhelmed. And what we can do for them in the long run is make sure we educate them well, train them well, we respect the nurses, don't treat them as somebody below us, but equal to us. We need to treat them with compassion. We need to incentivize their training, give them good food, better housing, offer them some co-curricular activities and extracurricular activities. Have a system by which they have exams every 1 to 2 years so that they update their knowledge. Give them mentors, trainers, send them for conferences, give them e-learning courses, and improve the nurse to patient ratio. This will definitely improve the backbone of our healthcare system. The following slides, the slides which are to come, thanks to Dr. Viraj Suvarna, who's a dear friend of mine, and Rajesh, and he helped me to get this data together. So people are not just looking at the outbreak with a tunnel vision. What people are trying to see is how are these people presenting? Are there more males to females who are presenting with COVID-19? How are the women faring? How are the men faring? Is age a factor which affects the morbidity of this disease in the two genders? So I think this slide is a very important slide, and I'd like to go a little bit in depth. There are certain points that have been talked about. One could be that the male sex hormones depress immunity. Also, the gene for the ACE2 receptor is present on the X chromosome. Now, because women have two X chromosomes, it is possible that this gives us more protection than it does for the male who expresses only one X chromosome, because the X chromosomes also contain the genes for immunity. So women have more immunity to the SARS virus. Also, and this is the one which primes the spike protein so that the virus attaches to the ACE2 receptors. So it's possible that the male has more of this TMPRSS2, which again facilitates the entry of the virus. It has been observed that the virus lasts for a longer time in males than in females. I'm not sure whether I should say this, but males are not as disciplined as women. They have more risk-taking behavior, they smoke more, have more alcohol, and do not follow hand hygiene and other precautions as well as women do. I think, and many people think, that males are generally less resilient than females. And we all know that even preterm females catch up better than preterm males. Many papers are coming up which are showing the protective effects of estrogen and progesterone. In fact, we know that progesterone is an immune modulator and therefore gives more protection than estrogen. Many males have beards and mustaches which are part of the T-zone and they keep touching them. So it's possible that the hair becomes a fomite for transmitting this virus. As a woman, I remember always telling my children, wash your hands with soap and water, wash them thoroughly, brush your teeth. So I have a feeling women are perhaps more cognizant of the hand hygiene, and therefore women are known to probably wash hands more often than men. These could be some of the reasons that make women a little more safer than men as far as COVID-19 is concerned. So again, going a little more in depth, it's possible that the higher level of estrogen contributes to the immunity, and the fact that the women have two X chromosomes which have these immune-related genes could be a factor which heightens the immune response of women. Men can have higher rates of blood pressure, high blood pressure, type 2 diabetes, and obstructive pulmonary disease, and all these can increase the risk of complications and death from COVID-19. So there are many papers which are coming out currently which focus on the severity and mortality and gender differences in these patients. And what they found is older age and higher number of comorbidities were associated with higher severity and mortality in patients with COVID-19. But also they showed that the number of men who died from COVID-19 was 2.4 times higher than that of women. So perhaps in these set of patients, the gender role in mortality has to be looked into. So now if you look at this graph, you will see that there were equal number of men and women who had mild and moderate and severe disease. But you look at those who had serious disease, and there were definitely more males than females in this group. If you look at these two graphs, you will see that people who were more than 65, there were more people in this group who suffered mortality. And as the age decreased, the chances of survival became better. Now, if you look at the male to female ratio in those who survived in the lower graph, you will see that more male diseased as compared to females. So, the conclusion of many papers is that adverse outcomes of COVID-19 seem to be associated morbidities like hypertension, cardiovascular disease, lung disease, but also because there is a tendency for men to smoke and drink more than women. There are quite a few papers gathering this data, and data collected by Global Health 50/50 showed that in Italy, they had 71% of all case deaths attributed to men, with only 29% being to women. Spain also was a major hotspot some time back, and 65% of deaths were attributed to men. They've also shown that men are more susceptible to viruses, and that is for the number of reasons that I showed in my previous slide. And this is a very nice graph. I'd like you to pay attention to it, wherein many places they have shown that the percentages of deaths by gender in COVID-19 was more for men than for women. Here again, you will see that the percentage of deaths was more in the 61 to 70 group, with more men succumbing in this group. And depending on the kind of comorbidities, the death rate was higher. So again, to summarize, many studies have shown that men accounted for 58% of all cases and 72% of deaths. 60% of those who were infected, that is the men, became sick. Then they showed that fatality rate among men was 65% higher than in women. And in South Korea, men accounted for nearly 62% of all cases, and infected men were 89% more likely to die than were women. They also noticed this gender difference in young children. Children younger than 16 showed that coronavirus affects more boys than girls. So I wish to thank the three authors of this wonderful book, Dr. Rajesh Parikh, Dr. Swapneil Parikh, and Mahira Desai. My journey into learning about SARS-CoV-2 began with them writing this book. Thank you, dear friends, for your very patient hearing.
Hello again, friends. Before I introduce Swapnil, I want to share a little anecdote with you all. Rajesh was taking a trip in the Sundarbans late January, and that is when Swapnil called him and said, "Look, Dad, there's likely to be, excuse me, likely to be a epidemic coming up," and both of them over the phone discussed that they would like to research this a little more, and that got the ball rolling, and that is how Rajesh, Swapnil, and Mahira started working on this book, which they completed in about 6 weeks' time. So, Swapnil, thank you for joining us. I'd like to mention a few things about Swapnil. He's the co-founder and CEO of a healthcare startup called DIY Health. He has created many innovations during these times, like the safest kiosk and the safer clinic. The BMC has approved of these, and many private hospitals have got these into their system for keeping doctors and patients safe. Swapnil has a special interest in treating lifestyle diseases like diabetes and obesity. He's an advisor to the BMC in Mumbai. He's a co-investigator for several research projects related to the SARS-CoV-2 virus at Kasturba and Nair Hospital. And recently, he was part of the team that initiated the plasmapheresis trial at Nair and Kasturba. Over to you, Swapnil.
Hi, everyone. Thank you so much for that introduction. It's a pleasure to be here to give you this talk today. I'm going to talk about how you can get your practice safe and COVID-19 ready. I'm going to skip past the introduction because everyone did such a good job already. The only thing I would like to add to the virology is the bilipid envelope is extremely sensitive to soap. It's just like you can wash grease off your hand. This is essentially like grease. So soap is very effective at dissolving the bilipid envelope. That's why it's so important to use soap and water to wash your hands. I want to quickly talk about the epidemiology a little, about how this transmits. It's mainly through droplet spread. When we talk about airborne spread, that refers to aerosols or droplet nuclei. Those are less than 5 microns in size. This distinction is a little arbitrary. Some individuals with the same virus can produce droplet nuclei. There are other factors involved. Direct contact is another mode. It can spread through fomites. The fecal oral route is becoming increasingly important. A vehicle-borne spread as well. Food, water, human bodily fluids. Vertical transmission is something that is being actively studied. It was covered in the previous presentation, as well as sexual transmission. Importantly, the period of infectivity can start a few days before the onset of symptoms, possibly may continue after the person apparently recovers, and asymptomatic individuals are infectious. That is to say, asymptomatic and pre-symptomatic individuals are infectious. They may account for up to 50% of the transmission chain. This little animation will show you what happens when a person coughs in an enclosed space. This is in a plane, but the same applies in any enclosed space. So you can see the infectious droplets that are being generated and how they disseminate. And although it's the individuals closest to the sick person who are at highest risk, there's a potential risk, a lower risk to everybody, as you can see. This animation represents a study from on the infection, on how the virus spread at a restaurant in Wuhan. So if you look at the tables highlighted in blue, sorry, just give me 1 second. Sorry, give me a second.
Great. Hello, friends. So while we are adjusting this glitch, let me share a few questions that have come from the audience. My first question is to you, Rajesh. Rajesh, can you hear me?
Yeah, I'm on. I was just reading something else. Okay, go.
Okay, great. So one question is, Rajesh, and I think it's a very relevant question. What mental health consequences can be there not for everybody in general, but for healthcare workers?
Well, the mental health consequences for healthcare workers are clearly far more intense than those for people in general. Let me clarify, we don't really know. Nothing on this magnitude and scale has occurred in our history. So we are actually in the middle of a very bizarre and grotesque social experiment, social and psychological experiment. And it'll take years for us to fully understand what people are going through. What we are seeing, of course, is anxiety, depression. There have been healthcare workers who've committed suicide. There was a doctor in New York City. She was working overtime, looking after these patients, no past history of any mental illness, and one day she killed herself. We do have data, however, from what happened in 2008 following SARS, and there are papers published which looked at people who are in quarantine as opposed to those who are not in quarantine, and they found a 2 to 3 times higher risk of anxiety, post-traumatic stress disorder, behavioral issues such as a phobia of going out in crowds. So these have been studied. Then there has been a lot of data over the years on social isolation and loneliness. As many of us know, loneliness is now considered to be an epidemic, actually, in the West, in the United States, and in Europe. And there is data on the physiological and psychological effects of social isolation. The most glaring of this is that there is a 26% higher risk of death in people who are in social isolation compared to those who are not. And some have calibrated that risk to say that social isolation is the equivalent of smoking 15 cigarettes a day when it comes to the consequences on health. So there are undoubtedly profound consequences, mental consequences of what's happening today. The studies have just started. Right now, that's not a priority. We need to save lives. But in the years to come, we'll be studying this, going by past experience. There are likely to be severe consequences.
Thank you, Rajesh. This was extremely informative. Rishabh, there's one question for you. It's going to be a prize-winning answer. If you can answer it, and you'll get 10 out of 10. So
what's the prize?
What's the prize?
10 on 10 is not prize.
Sorry, what do you say? No, 10 on 10 is the A+ star. So listen carefully, Rishabh. Which vaccine in the trial looks most promising and why?
Can't hear you, Rishabh.
Can't hear you.
Rishabh, you're muted, I think. We can't hear you. Just get the mute button off.
Yeah, I'm so sorry. I just saw it now. Yeah. You guys can hear me now?
Yeah, very clearly.
Very.
Thank you.
Yeah, actually, yeah, that's a very difficult question. I'm not I'm a vaccine person and immunologist. So, but, I will try to answer this question. I believe a protein-derived vaccine has much higher potential to succeed. And the reason I say that is because of already prevailing vaccines on the same concept. And I'll go back to Sanofi again. They are the ones who actually manufacture the flu block vaccine every year, and they have done it very successfully. And I know they are in the protein batch production phase, and they will go into the trial in the next couple of months. So I'm fingers crossed. I know there are trials which are going on around mRNA vaccine, but historically we never had an RNA-based vaccine license. So.
Yeah.
Thank you, Rishabh. Now there's a question for Swapneil, although he's not already on. Swapneil, are you on?
Yeah, I am.
In Swapneil, are you on? There's a question for you even before you started. But would you like to go on to your presentation right now?
We're having technological issues so
okay.
Waiting to figure that out.
Can you answer questions instead? There are already 4 questions for you.
Sure.
So people are anticipating what you're going to do to help doctors and patients. So one interesting question that has come up, because I think people have heard you before, And the same question is being asked to you again, to talk a little bit about herd immunity. Difficult?
Okay. So herd immunity refers to the indirect protection that susceptible individuals get because of the immunity in society as a large. So let's say there are 100 people in a room and 90 of them are immune to a particular virus. Then what happens is the 10 people who are not immune get some protection against infection. Whereas if there was one infected person and all the other 99 people had no immunity, then all 99 could potentially get infected. So herd immunity is an indirect protection that individuals get because of the immunity of other people in the community. This is the basic objective of vaccination campaigns. So if you achieve herd immunity through vaccination campaigns, that's excellent. If you achieve herd immunity in a pandemic, that's devastating. If we allow 60 or 70% of the population to get infected very, very quickly in a, let's say 3 to 6 month period, it's going to exceed what we call the peak capacity of the healthcare system to look after these people. So we'll have a lot of deaths. And additionally, what will happen is we're not giving scientists adequate time to develop vaccines, new therapies. Like when the infection first started in Wuhan, they didn't know about thrombosis. This is something that we found out right now, and this has fundamentally changed our treatment protocols, improved the standard of care. So it's really important we try and delay as many infections as possible for as long as possible, both so we allow the healthcare system to respond appropriately, but also so that we give scientists a chance to develop treatments and vaccines.
Firuza, if I may add, one of the powerful political proponents of herd immunity was the British Prime Minister, Boris Johnson. And, he's, of course, the counterpart of Donald Trump. And he was propounding it. And then he himself fell ill to COVID-19. He was in the ICU for 2 or maybe even 3 days. He was very critical. People didn't even know whether he would survive. He managed to survive. He came out. He thanked the doctors and the nurses. But more important, he suddenly stopped talking about herd immunity.
Well, we know that this virus is going to change many things, many of our thoughts. Swapneil, are you ready for another question? There's a co-registrar of yours from Jaslo who's asking you this.
Sure.
So he says that he's read about your kiosk, it's called Safer, right? Safer, and recently about the Safest. So he has some questions. How did you go about doing this? Because you're a doctor. How did you get into this? Interesting question.
So basically, I believe that responding to something like COVID-19 takes a multidisciplinary effort. It's not just nurses, it's not just doctors. Someone who's a sweeper in a hospital, like housekeeping staff, has as much of a role to play in infection control. By that same measure, engineers, people who are expert at HVAC systems also have as much of a role to play. So we tried to get a team together of people who are experts at different things. And we came up with a solution.
That sounds good. Rajesh, there's a question. If you can please take it. Give me a moment. He's asking, will the mental health of somebody who is going through COVID or who has been just diagnosed with COVID, will that have an impact on his or her physical health?
Yes, it should. Not necessarily will, but there's a high probability that it will. Because, in neuroscience, we now look upon the body as integrated, the brain being an integral part of the body. And there is a reciprocal relationship between physical health and mental health. And studies over the last 50 years have demonstrated that mental health, affects immune function, which is very critical in this illness. And so, yes, unless the mental health issues are addressed, there is likely to be a vicious cycle of where the mental health issues will reinforce the physical illness, and the physical illness in turn can contribute more to the mental health issues.
Great. Rishabh has a question for you. I'm not going to ask you whether I'll give you a 10 on 10, but it's a very, it's a question that says that you were one of the people in the epicenters of this. You recently said that now we are seeing less number of deaths. Is that something that is going to stay? The question says, are we happy with that? Or are you going to face an issue, or are the people going to again get infected, and are we again going to see a spike?
Sure. So, what happened was because of our delayed lockdown, we were not able to, kind of estimate the surge which were about to hit our hospital. And that is when the New York healthcare system crippled. Believe me or not, our health system is one of the top 4 systems in the New York state. And we had to create more than 400 beds. And those beds came out of the cafeteria, came out of the gym area. We also had to create tents outside the hospital. So, it was a disaster. So if we think 400 bed is actually creating another additional hospital. So what's going on now, the cases coming to the ER have significantly decreased, and our ERs are mostly empty right now. The fact is, people who have different disease, who would like to come to take care for their, CHF or heart attacks, chest pains and other stuff, they are not coming to the hospital because they are scared. And there are less COVID patients because we have been in the lockdown for last 2 months or so. The fact that we are planning to open the lockdown, it will most likely create a second wave. But my theory regarding this would be, I think this wave most likely will be much lower and much less significant when compared to the first wave. The fact is, the people who were most vulnerable, or people who were not that immune, did not have a stronger immunity, are the ones who succumbed to this virus in the first phase. So when this virus starts circulating again, it's going to, infect people who have much stronger immunity. So, I think the comorbidity and the mortality rate will be significantly lower in the second wave. But yes, we do expect a second wave. That's where we have still maintained all those protocols of creating additional beds in the New York area.
Rishabh, you answered. Yeah,
sorry,
go ahead.
I'm sorry, I interrupted you. Go ahead, Firuza, then I'll complete.
Go ahead, it's okay.
I just wanted to add, you said that Rishabh is in the epicenter. He's actually in the epicenter of the epicenter. And I think we need to congratulate him and his team, who have been right at the forefront. And we must also acknowledge what a tremendous job New York City, and in particular New York State, are doing in their effort to contain the pandemic, and led by their remarkable governor, Mr. Andrew Cuomo. I think they're doing a phenomenal job. A lot of people say, oh, New York is full, because New York is the gateway to America. New York is a gateway city. Everybody comes in and out through New York. And that they have weathered this and are now emerging successful, I think is a tremendous testimonial to people like Dr. Rishabh Mishra and the people in power in the state of New York.
I couldn't agree with you more, Rajesh. Swapneil, I think you are ready now, and we are ready to listen to you. Ready to go? 1, 2, 3.
So yeah, I promise. I promise these systems will make the clinic more able to deal with COVID-19 than I was able to make my computer deal with this presentation. But let's start. Next slide, please. We can skip this. Let's skip this also. So I just want to briefly talk about the transmission. Droplet spread refers to the spread of using droplets that are bigger than 5 microns in size. When we talk about airborne We're referring to aerosols or droplet nuclei. These are less than 5 microns in size. Direct contact and fomites also are important. Fecal-oral route is becoming increasingly important. Vehicle-borne spread, food, water, um, human fluids. Vertical, increasingly, we are finding some data that this is possible, and sexual as well. Dr. Firuza Parikh's presentation dealt with this. Importantly, individuals can be infectious when they're asymptomatic. They can be infectious in the pre-incubation period, so in the pre-symptomatic period. And they can possibly be infectious after they've apparently recovered. If we could play the animation, please. So in this animation, we're seeing how the virus spreads via droplets in an enclosed environment. This is in a plane, but it's equally applicable in a clinic. You can see the individuals highlighted around the sick person are at highest risk of exposure, but almost everyone was exposed, had a lower risk of exposure. Next graphic, please. In this graphic, we can see 3 tables highlighted in blue. The one in the middle had a COVID-19 patient. The droplets spread from this individual via the draft in the air conditioning. So you can see the blue arrows represent the uncontaminated air when it hit the patient. The droplets spread to the table behind this person. They then hit the wall and they rebounded off and went to the table closer towards the air conditioning. So, recirculating air system in an enclosed space in the absence of filtration can be problematic. Next graphic, please. So here we can see based on the different droplet size. So we have an arbitrary division between a droplet and droplet nuclei, which is 5 microns. Importantly, the same infection in different individuals and in different settings can either spread mainly by droplet or droplet nuclei. So we can see when there's droplet nuclei, the distance that it spreads over increases tremendously. And more importantly, these droplet nuclei, they don't settle down. They can stay suspended in the air. That's why the aerosols. Next slide, please. So how long does the virus survive on various objects? In the aerosolized form, it's thought about 4 hours. On copper, about 4 hours. Cardboard, 24 hours. Stainless steel and plastic, 72 hours. And glass, 96. Next graphic, please. Next graphic, please. So here we can see just a visual representation of the different objects and how long the virus may possibly remain infectious on these objects. Next, please. I'm sure this has already been covered, but the only relevance here is that these practices dealing with diabetics, hypertensives, cardiovascular disease, cancer, obesity, geriatric clinics, these really need to take precautions because they have patients who are most at risk of poor outcomes. Next, please. Next. As you can see in the pyramid, in the graphic here, the mild cases and the asymptomatic cases, these are the vast majority. So we have to assume that this infection is everywhere. Any patient coming to the clinic could potentially be infectious, and that's why we need to take precautions. The ones who we can detect via screening methods represent the smaller minority. The clinical features have already been covered, but most importantly, cough, fever, breathlessness. Importantly, fever may not be present in all patients at symptom onset. Only about 50% of patients have fever at initial symptom onset. Of patients who will be hospitalized. And importantly, about 80 to 90% eventually do develop fever. So that just goes to show thermal screening may not be effective in up to half of patients who are symptomatic. If we may move on to the next graphic, please. Next, please. So this is the safer clinic that we created. But before that, I just want to stress this. Precautions are universal. That means, they need to be applied everywhere. We can't be selective about them. So the most important thing is how do we minimize exposure? So you use telemedicine. Dr. Rishabh spoke about that a little. Ask about symptoms. avoid relatives coming to the clinic as much as possible. Please ask the patients and anyone else coming to the clinic, including medical workers, to wear a mask. Limit the numbers in the clinic at any one time. So you can see in the clinic we designed, we limited it to 3 people in the clinic to maintain adequate distance between them. Screen patients both with history of symptoms, exposure risk, and also, if possible, thermal screening. If any patient comes into your practice and is a potential COVID-19 suspect, please keep an area in your clinic where the patient can be temporarily isolated and start taking all precautions in the meanwhile. Hand hygiene, respiratory hygiene is so important. Cannot stress this enough. Avoid touching your face as much as possible. So one common issue, I wear glasses. So, when you're wearing glasses, you'll find that the number of face touches increases, often to adjust the glasses. So what I do is I just tape my glasses on if I'm working. I just tape them onto the side of my forehead, and that just keeps them in place. I'm sure there are other better methods, but that's my low-cost solution. And then there are engineering solutions. So physical barriers, you can place a transparent acrylic sheet on your desk to create a physical barrier between you and the patient. Maintain distance. Learn to speak loudly, please. So, if you can speak over a distance of 1 to 2 meters, then you only need to get close to your patient when you're examining them. Other barriers like transparent curtains, air handling units, positive pressure in certain scenarios, negative pressure in others. Infection control and disinfection protocols are so important. They're freely available on the CDC website, on the from the Ministry of Health and Family Welfare. Please study these. They're so important. The WHO has great protocols as well. Fomites need to be avoided. So no jewelry, no rings, no Mangal Sutras, no religious ornaments, no pens. Avoid all of that. Don't take anything into your clinic space, and avoid taking anything out of your clinic space. So papers, everything needs to stay in your clinic space. I know the phone is a very difficult thing to say that you're not going to take your phone in with you. So then use alcohol swabs. You need to clean the case, the inside and the outside, and the phone itself. This typically takes 2 or 3 alcohol swabs. This isn't 100%, but please do clean your phone. The best way to keep your phone clean is to keep your hands clean. If you're a doctor who's at high risk, either because of your age or a pre-existing condition, then you need to reevaluate if you want to practice right now. Perhaps you can switch to a telemedicine-based practice and guide young people, young doctors, let them benefit from your experience using digital mediums. Really important, protect your family. So one of the things I do, because I am working with COVID-19 patients. I'm isolated from my family. I haven't met them in a while. But also when I come into my house, I take my shoes off outside the door. I use a hand sanitizer on my hands and feet before I enter. As soon as I enter, I have a staging area. It's a box. I take off my clothes. I put them into a bag. I tie up the bag, go straight in for a shower. So, you really have to be mindful about bringing potential infection into of course, I'm wearing PPE, but still, this is just an additional layer of safety. Please, can we have the next graphic? So inside the Safer Clinic, we created a glass glove panel. It was interactive. So there's a stethoscope going through it, automated BP check on the other side, SpO2 monitoring, and a two-way speaker system. So you can conduct a full patient examination with a completely sealed barrier. The doctor side had positive pressure, the patient side has negative pressure, and there's HEPA filters on both the inlet and the outlet. And in addition, we placed virus burners on the outlet. Next graphic, please. This is a little video. I'll talk you through it. So this is the clinic. We installed it at Mumbai's NSCI Dome facility. It has an airlock system. So when you enter, there's a pressure gauge. It tells you, that there's positive pressure in the airlock. You'll see the vent generating positive pressure. So essentially 2 air handling systems. The inner door opens only once this is the patient area. And in the clinic, these areas are actually sealed off and there are multiple entry points. This is the negative pressure. You can see the plastic just got pulled up to the vent. So any aerosols, droplets are going to get pulled into the system and filtered out. And there's the interactive glass glove panel. The containers are disinfection tins, so we place ethanol in them between each patient interaction. They're dipped into ethanol to completely disinfect them. And the chamber is completely hermetically sealed. We can move on to the next graphic. This is the testing kiosk. We called it the safest testing kiosk. So by the way, safest is safe and fast, safe assessment, fast, effective swab test. And the safer clinic was safe assessment, fast and effective resolution. Again, this has a glass glove panel, disinfection tins. If we can see the next graphic, there's positive pressure inside. I'm sorry, this is inverted, but just one thing I want to show you here, and this you see this little plastic, white plastic object on the doors. So it basically means you don't need to touch the doors. These are very cheap. They just cost 150 rupees, about $2. We can move on to the next. Next, please. This is a little chatbot my organization created. So it allows for an automated history taking in patients. It triages them. If the gender is female, it asks about pregnancy, how sick the person is feeling. It asks for any life-threatening symptoms which would necessitate emergency care in ambulance. If there are none, it asks for urgent symptoms which would require urgent care, an ER visit. So let's say there's hemoptysis, instructs the patient that they need to go to an emergency room and to use a mask or a tire cloth around their mouth and nose. Then it's asking about what activities they can perform, whether they're breathing harder and faster, whether there's been any breathlessness. Guides the patient through understanding their symptoms, doing a self-assessment at home, asks them about a cough, and then a whole variety of other symptoms. So basically, this system, it's available for free, by the way, on our website, so everyone can use it. Please feel free to use it, repurpose it. All our solutions are open sourced. It could be my absolute pleasure if my medical colleagues can benefit from all of these. And you can reach out to me. I'm more than happy to guide my colleagues. We can move on to the next slide. So basically, this system allows you to, that our company created, do-it-yourself health. It allows the patient to be assessed and you get a report. So then you can take the necessary precautions, you can structure it. So if there is a patient who is potentially symptomatic, maybe you could call them later in the day, at the end of the day, right before you're going to disinfect the clinic, or you could just use telemedicine. We can move on to the next slide. Skip the slide, please. So here we can see the hierarchy of controls in infection control. And you can see that PPE is the least effective method. So elimination, source control, that's the most important. Substitution, using other methods, second most important. Engineering controls, like we discussed, ventilation systems. Administrative controls, changing the way people work. If you don't need a receptionist, please don't have a receptionist. If you don't need an assistant, please don't have an assistant. Reduce the number of people to absolutely what is necessary. And of course, use PPE, but please do everything else also. As you can see, PPE is the least effective method of infection control. So the PPE kit, next graphic, please. The PPE kit includes a face shield or a goggle. The face shield is preferred. An N95 or higher respirator, non-sterile single-use gloves. I use non-powdered gloves, a gown, and all of the above need to be used in the OPD setting as well. The WHO recommends surgical masks for the OPD. I prefer to use an N95 there as well. Importantly, if you're going to use an N95 mask, you need to do a fit test. This is really important. You need to know what your size is. And every time you put the mask on, you need to check that there's no air leaks. So how you do this is, I'm going to take off my glasses and show you. So when the mask is on, and after you've sealed it at the the adjustment at the nose, you need to cup your hands and check if there's any air leak when you breathe out. You'll commonly also feel it on your eyes, or if you're wearing glasses, they'll fog up. You'll see them starting to mist up if there's an air leak. So really important, fit test, and every time you put on a mask, you need to check that it's used appropriately. Next, please. So just to understand the different types of masks, the two that most people are aware of are the surgical masks and the N95 masks. There are also elastometric half face piece respirators. The important part is that the elastometric respirators are reusable. You can use them multiple times. You can change the filter. And the other main difference is that the N95 and the elastometric are tight fitting, whereas a surgical mask is loose fitting. There are also devices available that go on over the surgical mask and tighten the fit of the surgical mask. In theory, these would make them a little safer. You also get elastomeric full face piece respirators, and this is expensive, but it is the single most effective and comfortable way to say safe. It's called PAPR, or powered air purifying respirators. These are really only used in the ICU setting or in aerosol generating activities. But if you're a critical care physician, petition your hospital to get these for you. They're very, very effective. Next, please. When you get an N95 mask, you'll see NIOSH written there. So make sure that NIOSH is written correctly, it's spelled correctly. You'll see a TC approval number. So check that number and you'll see a lot number. If you go onto the CDC website, they have a tool that allows you to input these numbers and will guide you to know whether it's an authentic mask or not. There are a lot of fake N95 masks going around. So before you identify a supplier, please make sure they're authentic. The tool is available for free on the CDC website. Next, please. So the three key factors required for a respirator to be effective. The first is it must be put on correctly and worn during the exposure period. So you can't take it off before you leave the patient area. Avoid touching it and adjusting it and sliding it around. It needs to fit snugly. So you need to make sure there are no gaps. If there are gaps, it's not effective. And you'll see the correct way of putting it on. So observe that the noseband is up and it's been sealed carefully. Look at the position of the headbands. In the incorrect position, you'll see that the noseband is down. Both the headbands have been put in the same place. This is incorrect. And this is really important. So the anterior surface of the mask, the front of the mask, has virus on it. It's potentially contaminated. So if you take that off and you keep it right below your nose and your mouth, you are in effect increasing your risk of exposure when you inhale. So absolutely do not keep your mask like that at any point of time. It's either on you or it's removed and discarded. Can we move on to the next slide? So donning PPE is how you put PPE on. By the way, I'm sorry if I didn't clarify, but PPE is personal protective equipment. So there are multiple different methods to put it on. I've put on a CDC graphic of the method I use to don PPE. There is some training required, and ideally every time, but at least in the initial periods, have a PPE buddy, someone who's trained, who can guide you. Your first step is to identify and gather all the PPE and make sure it's the right size. Perform hand hygiene. Then put on your gown. This might require help to secure it at the back. Next, put on the mask. An N95 is preferred. Next is the eye protection. A face shield is preferred. Perform hand hygiene. Once your hands air dry, do not shake them. Just let them air dry. Do not use a towel. You can use clean, sterile tissues, but in the absence of that, just let them air dry. Put your gloves on next and make sure that the gloves cover the cuff of your gown. Next, please. Doffing PPE refers to taking it off. Again, there is more than one method. This is the method I use. Similarly, training and supervision and a PPE buddy is required. So first step is perform hand hygiene over the gloves. You can see in the graphic how the gloves are being removed. So how the gown and the gloves are being removed together. So the first step would actually include if it's been tied and secured at the back, then you might need to break those, or someone might need to help you untie those. But once you do that, you'll see how the gown is being removed, and the contaminated surface, that's the front surface, is being balled up, and the gloves are being removed into the gown. So it's the surface that was actually in contact with the scrubs that is now on the outside. As soon as that's done, perform hand hygiene. Sorry, really important, make sure you are discarding of your PPE following your local biomedical waste policies. You can't just leave this lying around. So after you've discarded of the gown and gloves appropriately, perform hand hygiene. Remove the eye protection next. Really important, do not touch the front of the eye protection. It needs to be removed using the strap. So if this was don't grab it from the front. You have to use the headband at the back to remove it. Once that's done, discard appropriately, perform hand hygiene. Similarly with the mask, do not touch the front of the mask to remove it. You need to use the headbands to remove it. Again, discard it and perform hand hygiene. Really important, please follow your hospital or local government's biomedical waste policy. It risks other people otherwise. Next slide, please. A common question is, how long will this last? The truth is, nobody knows, right? We don't know. If there was anyone who had any kind of prophetic abilities and can accurately predict how the COVID-19 pandemic is going to pan out, well, then perhaps they should have let us know that this was coming to begin with. So nobody knows what's going to happen. Based on the evidence we have now, it's likely that this pandemic is going to, in the absence of a vaccine or an effective treatment, it's going to pan out over a 12 to 18-month period. And it's possible after this period, it's going to become a seasonal virus that will come back every year or 2 years or longer, depending on how long the immune protection lasts. So we just have to adjust to a new normal. I also hear many people saying that this virus is not that dangerous. Ebola is more dangerous. SARS-CoV-1 was more dangerous. MERS is more dangerous. And while that might be true on an individual level, certainly the case fatality rate of these viruses was higher. Because the SARS-CoV-2 viruses it's difficult to see the transmission, because asymptomatic transmission plays such an important role. Is going to infect more people, and therefore although the percentage of people who die may be lower, the absolute number is likely to be so much higher. And we learned earlier that with the 1918 Spanish flu pandemic, there wasn't just one wave, there were 3 waves. So you can see we might be on the first wave, which is the smallest wave. The second wave might hit India when we're dealing with dengue, malaria, and other tropical illnesses. By the way, respiratory pathogens behave differently in tropical countries. So in temperate countries, they typically spike in the winter time. In tropical countries, there's a spike in the post-monsoon period as well as in the winter time. So it's entirely possible that we'll be dealing with the escalation of the pandemic, a second wave in the post-monsoon period. The reason this happens is because in the winter, people cluster indoors. In the summer, they're outdoors. But in India, because of the monsoons, people do also tend to cluster indoors. There are other factors as well relating to temperature and humidity. So, right, we have to adjust to a new normal. We have to gear up our practices for a prolonged period where we might have to deal with this. Can we move on to the next slide? So thank you. I hope this was helpful. I apologize for the technical glitch we experienced earlier. So that's my website, www.diy.health. You can go on there. It's a free website. Everything we do, all the plans are available for free up there. So you can do it yourself. You can reach out to me if you need my help, and I'm more than happy to do that. This is a quote by the philosopher and scientist Karl Popper. And it's also in our book. Our knowledge can only be finite, while our ignorance must necessarily be infinite. This is a new pathogen. It's a new virus. It's a new disease. And much of what we know about it is an evolving process. So it's important to recognize that what we think holds true today may not hold true tomorrow. But the certain basics that have served us well as regards infection control, we should continue to do those. Thank you. We're done.
Thank you, Rajesh. Thank you, Rishabh. Thank you, Swapnil. The questions are not stopping. Would you be okay to give you at least 2 questions each, Rajesh?
Sure, I can take 2 questions. And then I have a
Sure.
meeting to attend, so I will excuse myself.
Sure, I realize that. So I'll ask you those 2 questions first.
Okay.
Both of these are very pertinent questions, not very academic, but it comes from a lady who's a gynac. Husband is an anesthetist. They have 3 children, and they don't know what to do with them. So we are requesting you that since you have written a book on this pandemic, is there something that you can write which will keep the children busy and make the parents understand what is to be done once this pandemic is over and we go to work?
Is there a price? Is there a prize for the right answer?
You could have used
Today's
it
mothers
20 years ago on us. You could have used it 20 years ago on us.
I know. If there is no prize, let me just answer honestly. I have 6 children and a wife, and I don't know what to do with them. So if anybody has better ideas, I'm ready to listen. But no, thank you. Actually, the question is timely. You know, we are writing 2 books now for children. Penguin India, after the success of our first book, got some requests. Wow. And they requested us to write 2 books, one for children age 6 to 12 and the other for children age 13 to 18. And we're putting them together. But since yours is the first question, if you text us your email, I'll send you some chapters from it. But you know, there's another thing, and that's a behavioral strategy. You know, somebody once wrote that nobody on his deathbed ever said, "I wish I'd spent more time at the office." Almost everybody wishes they'd spend more time with the family. This is our opportunity to do that. This is our opportunity to enjoy our time with the family, time with the children. You'll miss it afterwards. So make the most of it. You can play games. You can chat with them. You can get to know them better. Our 3 children have grown up. And when I look back, when Firuza and I both look back, we really miss the days when they were young and the fun that we would have with them. So cherish this time with your family. But for specific things, get in touch. We will send you an advanced copy of our book. Complimentary. Okay.
So, thank you, Rajesh. This question I think all 4 of us can address. It's a little awkward question, but anyway, I'll go ahead because we are medical professionals. There's a person who's a frontliner in the ICU, and he has no time for his family and there's no time for sex. Every time he goes home, his wife is morbidly afraid of making out. That's what he says. So, Rajesh, question to you. Rishabh, question to you. Maybe I can address some of this and still question to you. If you all think it's appropriate to answer.
It is definitely appropriate, and it is an important question. So there are 2 parts over here, you know, and one is, I think, something he needs to talk to his wife about, that there is a small possibility that COVID-19 may be sexually transmitted. Some recent studies, I think they're from China, looking at the semen of patients who have recovered from COVID-19, have seen RNA fragments in the semen, not the entire virus, but fragments of RNA. So they're not sure whether it can be transmitted that way or not. But it can certainly be transmitted through physical contact. And, you know, unless they're in an IVF clinic, I can't imagine how anybody would have sex without, you know, physical contact. So there is a certain degree of risk for the wife. And I think she needs to understand that it's not just a question of the person coming tired and not being interested in her. That may be part of it. But there's also the safety angle. And to the doctor who's asking the question, I can only tell him that this too shall pass. This is not going to be around forever, thanks to frontline people like Rishabh and Swapneil and others. Okay, we will overcome. We have overcome worse pandemics in the past. Well, we haven't, but our ancestors, our parents, grandparents, and in some cases, great-grandparents have survived through swine flu. You know, 16 million Indians died during the swine flu, 6% of our population. 16 million people out of the population at that time is enormous. Imagine 6% of our population today passing out. But we are around because our ancestors survived. That's why all of us participants in this webinar are around today. We too, as a species, will survive. And then there will be enough time, and you must take 2 weeks off, take your wife on a second honeymoon, and make up for everything that she has been deprived of.
That's very appropriate. That's a very appropriate answer. Rishabh, would you like to add something? Because you are the epicenter of the epicenter. So just one more thing which anyone can talk. Have any marriages broken down or relationships gone sour because of this? And any of you can comment on this.
Sure. I mean, I agree with what Dr. Rajesh Parikh mentioned. He's beautifully, summarized it up. It's emotionally challenging for the family. I mean, the separation is real, and it's mentally as well as emotionally draining to both the family members, and I mean, not only husband and wife, also the kid in the family, or other folks. What I have seen is there is tremendous opportunity for us to maintain, a safety protocol within the family by maintaining all these isolation protocols even at home. And we should actually, maintain those in the best interest of all the family members, And as Dr. Parikh mentioned, this too shall pass. And as he suggested, 2 weeks of vacation after that for a honeymoon, a second honeymoon or a third honeymoon would be a great opportunity to intermingle again.
Rishabh, with the same person, right?
Pardon?
Rishabh, you're
Yes.
talking about another honeymoon with the same person, right?
Absolutely.
Wow, Rishabh, that's amazing.
Swapneil, anything to add?
Just that this is the price of service. I mean, there are hardships that come with this job, and this is part of our commitment to our patients. It's not an easy job. It can be isolating at times. There's no easy answer, but it will pass, and we do what we do. It's our time to serve society. We have to think about more than ourselves.
True. If we have time, I think we have time for one or two more questions. There's a question to me, and it says, when can we start doing IVF on our patients? So there are two aspects here. Just give me a moment. Let me see if there's any other question related to this, which I can kind of team up. Yeah. So there are two sets of answers for this. The first is, be ready when we are flattening the curve. This is how I look at it. We'll be ready when we are mentally and physically fit, because all of us are going through times of stress. We'll be ready when we learn how to be compassionate and kind and treat everybody equally. We'll be ready when we have done dry runs. That is, like Swapneil said, how to don and doff. We'll be ready when our patients are ready. And when will our patients be ready? So there are certain guidelines that have been given to us by ASRM, the American Society for Reproductive Medicine, and the European Society, which is called ESHRE. There are certain guidelines and SOPs that we have almost finished currently for our clinic at Fertility Just Low. And what we plan to do is first make an inventory. We'll make an inventory to see who are the patients who will be ready to start. These have to be fit patients. We'll probably use Swapneil's app for triaging patients and healthcare workers. We'll use ESHRE's app, which is for triaging patients and healthcare workers. We'll make sure that we have HEPA filters, we have air purifiers, we have plasma burners. We'll make sure that all our patients who are going to come in and our doctors are not symptomatic, and some of them are tested. it may be worthwhile. I don't know whether you all will agree with me, but we may do some antibody testing that might at some point give us an idea who can be the frontliners for us in IVF. We will perhaps look at our inventory for PPEs. We'll make sure the rest of the hospital has enough of oxygen supply, we'll have enough of PPEs, we'll have enough anestheticians spared. We'll make sure our psychiatrists and our counselors are ready to go and guide our patients on how to go ahead. We will probably interact very closely with our admin and our team. In fact, right now, we have a team of 50. We are interacting daily on our WhatsApp groups. Many of us come up with solutions, some of us come up with problems, and we are there as a group. Sometimes to begin the day, we start with a funny story or an anecdote to break the tension that builds up. And please, all of you who are listening from please to top up your nitrogen. You should be daily testing the levels of nitrogen. A word of caution here, be very careful, wear your PPE when you start doing your freezing and thawing, because we don't know liquid nitrogen can be a carrier for the virus, although people are advising us to use what is known as liquid nitrogen. We want to know whether these kind of gadgets will be available. Telemedicine will be extremely important in these times. Already we are doing telemedicine. All of us, there are about 12 doctors of us who are probably talking uh, anywhere from 10 to 15 hours daily with our patients. They get a sense of security, and we are happy that we are able to converse with them, allay some of the anxieties and fear. The commonest question that is asked to us is, when can we start? And it's difficult to explain to patients right now that this is not the time to start. We are getting ourselves ready to keep the patients and ourselves safe. What we have planned is we'll have three teams. We have Team A, Team B, and Team C. Team A will function for about 10 days, Team B will function for the next 10 days, and Team C will be a standby. In case somebody falls sick in one or both of the teams, we will have the Team C that will intervene. I'm always seeking for answers to some of your questions, and I'd be happy if some of you who are in the audience guide us onto how to go ahead. This has to be a collective effort, it has to be a concerted effort. We need the inputs not only of gynecologists and IVF specialists, we need inputs from people like Rajesh, Rishabh, Swapneil. We need inputs from people who are very savvy with the internet, very savvy with IT. And of course, we need inputs from our patients. We have to be very careful of the legal situation. We have to follow all the guidelines given by the government of India and the BMC. We have to read. We have to attend seminars, and we have to update our knowledge, because daily there are new guidelines coming in. There is new science that is emerging. Last month, there was an article in a very prestigious journal which said there is no evidence of RT-PCR being positive in semen. 3 days ago, there's an article saying there is 17% of people who were either mildly affected or severely affected who showed the virus. Now, luckily, the testicle has a privileged immunity. People have not shown great expression of ACE2 and TMPRSS in some of the apparatus of the testes. But as Rajesh said, this can be transmitted through saliva, through semen, and also there's an anxiety and a fever. They've also shown that the viral mechanism and the receptors are present in the embryo, although not necessarily expressed in the oocyte, because the oocyte has the zona pellucida. So everybody, we have lots to think, and let's utilize this time in spreading compassion and spreading knowledge. I thank you all very much for a very patient and interesting webinar. If there are any more questions that you all would like to address, and if there is time, I'm happy to ask people questions. Any comments, Rajesh, Rishabh, Swapneil?
Yeah, I just like to quickly thank you, thank Rishabh, thanks Swapneil, most of all, thank Docplexus for hosting this webinar and inviting us to be a part of it. I'd also like to thank our co-author, Mahira Desai, not just for the work on the book, but the tremendous research that she has done, which made it possible not just to write the book, but do this talk as well. And finally, Munira Kapadia, she's a clinical psychologist who works with us, is a part of our medical research team, and she has also been working tirelessly over the past 2 months, culling all the data. We've gone through nearly 400 different articles and books to put everything together. So I'd like to thank Mahira, Munira, Rishabh, Swapneil, you, Firuza, and thank you, Dr. Plus, and of course, thank you for all the participants in this webinar.
I'll just add thank you likewise to everybody. Thank you to all the viewers, Docplexus, Dr. Rajesh Parikh, Dr. Firuza Parikh, our co-authors. I also want to thank you, Dr. Rishabh, for taking the time out to come here. And I think I speak for all of us in India, in the medical community in India, when I say that we stand in solidarity with our brothers and sisters in the medical community in New York in their time of crisis. Thank you for everything you're doing there, and we're with you in spirit.
Thank you, Docplexus, for this wonderful. Go ahead, Rishabh.
Sorry, yeah. Thank you, Swapnil, for those kind words. And absolutely, we are in this together. It's an honor and privilege to share this platform with all of you guys. And Swapnil, especially, the incredible work you're doing in the public health, as medical, community, we had lost trust in all these leading organizations like CDC and WHO. I've seen my colleagues sick, and some of them have actually succumbed to this virus. And now we can be a Monday morning quarterback and see some of these guidelines which were actually presented to us. For example, the PPE, we were told that actually you don't need to wear N95. A regular mask is something which can help you preventing the disease spread within the hospital. But we realized a week later that that was not the case when we started seeing our colleagues collapsing every second and third day. And it has been real suffering and misery, not only for the patients, their families. I think this was a big lesson for all of us, and I'm glad the world is going to put more emphasis on stabilizing and improving our healthcare infrastructure. Again, thank you so much for this opportunity, and I'm glad I was able to share some of my experiences with you all. And if there's any question, I'm more than willing to answer later.
Thank you, Docplexus.